Okay, well, welcome everybody, and thanks for joining today's Queen's Global Oncology Live Critical Appraisal Masterclass. My name is Scott Barry. I'm a medical oncologist and head of the Department of Oncology at Queen's University in Canada, and I'm very happy and proud to host today's event. Today's live event is a complimentary class that augments our online Masterclass in Critical Appraisal. And this is a 7-module online class that includes Dr. Thiwanko Richaratne, Dr. Nazak Hamad, Dr. Priya Ranganathan, Dr. Bishal Giawali, Dr. Chris Booth, and Dr. Ian Tannock, going through the key points of critical appraisal. And our first modules focus on the randomized clinical trial. And if you haven't had a chance to do it, I think I would recommend it highly. And it is a complement to today's online session. In terms of today's live critical appraisal masterclass, Dr. Manju Sengar is going to be doing a review of a randomized clinical trial. And that's going to take about 45 minutes. And in that review, she's going to be applying the principles that are outlined in the 7 modules online. And then we're going to have 45 minutes of small group breakout sessions facilitated by expert faculty from Canada and South Asia. We have representatives from Canada, Nepal, India, and Sri Lanka facilitating the small group sessions. And in those small group sessions, you'll have a chance to ask questions about the randomized clinical trial that is going to be presented, and or ask questions about principles that are presented in the online masterclass. I'd like to thank our small group facilitators today. They've taken the time and will be critical in making sure that you have a good understanding both of the randomized clinical trial that's going to be presented and have a chance to ask any questions about the online masterclass or any other issues around critical appraisal, especially around randomized clinical trials. And we have, as I said, a stellar group of faculty from both Canada and from across South Asia. So with that, I'm going to now present our keynote presenter. It's my great pleasure to welcome Dr. Manju Sengar. Dr. Sengar is a professor in medical oncology at the Tata Memorial Hospital in Mumbai. Dr. Sengar completed her training in medical oncology from the All India Institute of Medical Sciences in New Delhi. She has a postgraduate diploma in clinical trials from the London School of Hygiene and Tropical Medicine. She's a very active trialist, and Dr. Ranganathan affirmed today that she's a real star at the Tata and internationally. So we're very fortunate to have Dr. Sengar here to present for us today. Welcome, Manju.
Thank you, Scott. Thank you for that kind introduction. And I think Priya has given an unnecessary compliment. So thank you, everyone. I'm really grateful to the entire team who has organized this Critical Appraisal Masterclass, Scott, Laura, Priya, and there are many more who are working behind the scenes. So thank you very much. Special thanks to Priya because she has, provided several critical inputs to what I'm going to present today. And with that, I would like to begin this, and a warm welcome to all the participants who have joined from different parts of the world and from Southeast Asia mainly. What I'm going to do in next 45 minutes is to tell you that what is exactly critical appraisal, why it is needed, how it is done using an example of an article, so that we can utilize the same key concepts which Scott showed are available in terms of different modules on the website. So if you haven't done that, if you haven't looked at those modules, I strongly encourage you to do that because they really provide valuable insights for any clinical trial which you're going to appraise later on after the session. So why do we need critical appraisal? I think the commonest reason why we require critical appraisal is when you want to practice evidence-based medicine in your clinic and you want to find out what is the most appropriate treatment or appropriate diagnostic test for the patient sitting in front of you. And this has become highly relevant in last few years when we saw COVID and there was multitude of treatment and diagnostic tests which came in, and we needed to decide what is actually beneficial for our patient as compared to their claimed efficacy and benefits. At times you require critical appraisal when you get to see the news items like this, which promise a breakthrough, and there are questions in your mind as well as around you whether you should really change your practice. And that's when you need to do the critical appraisal to see whether there is a truth in this claim. A proportion of you would need critical appraisal when you have your own research idea and you want to see whether the question which you have asked, whether there are previous studies which have answered your question without a reasonable doubt. If not, then you pursue with your research question and your research study. So these are the three broad scenarios where you would need to do a critical appraisal of the research evidence. But what is critical appraisal? Critical appraisal is the process of systematically examining research evidence to assess its validity, results, and relevance before you use it to inform a decision. So three words are very important in this definition. One, it's a systematic process. You're looking at validity and you're looking at relevance. And that pretty much summarizes the entire critical appraisal. You're looking at the results, whether they are valid, what we call as internal validity, and you're looking at the results to see whether they are generalizable, usable, relevant, and meaningful for your patients, what we call as external validity. Internal validity practically means that the difference which you are observing between the intervention and comparator is attributable to intervention. And it hasn't come just because there are issues with the study design or there are systematic errors in the way you have selected and allocated the participants to the intervention and comparator arm, how you have conducted, how you have followed up, or the analysis which has been done. This is what we call as systematic error or bias, or they could be chance errors just because you have a very small sample and what you have got as a result is just by chance because of not enough power in the study. The other component is external validity, which basically starts from whether you've asked the right question, whether there is good enough reason to conduct the study, and is it applicable, whatever is being presented in the research paper, is it applicable to your patients or is it meaningful for your patients? And as I said, it's a systematic process. Any systematic process requires steps to be documented. So there has to be checklists for that. And we have freely available checklists which you can access depending on what type of article you are appraising, whether it's an RCT, whether it's a systematic review, economic analysis, you can look at these checklists, utilize them in doing the critical appraisal. If you really want to read something very simple, very interesting, I recommend you this book, How to Read a Paper by Trisha Greenhalgh, which is one of the most interesting read for a topic which is not really considered very favorite, that is evidence-based medicine. So if you get time, do try and read it. So let's move to our article and see how we do the critical appraisal. And our article is ibrutinib plus bendamustine and rituximab in untreated mantle cell lymphoma, also called the SHINE study, published on June 3rd, 2022 in New England Journal of Medicine. Before we go to actual article, I just want to briefly talk about mantle cell lymphoma because some of you may not be treating lymphomas. So mantle cell lymphoma is a B-cell non-Hodgkin's lymphoma, presence in relatively elderly individuals. It has a variable clinical course, but it is incurable. So depending on you have, aggressive form, the median overall survival is around 1.2 years versus if you have a relatively indolent disease, the median overall survival is 8 years. But the bottom line is it is not curable. The treatment is dependent on whether the person is fit for transplant or not. If the person is fit for transplant, you go ahead with induction chemotherapy, which is either R-CHOP in combination with RDHAP, and then you do transplant and then followed by rituximab maintenance for 3 years. In the transplant ineligible subjects, there are several options. One of them is bendamustine rituximab or using R-CHOP followed by R maintenance. If the subject has, if the patient has indolent disease and there are no symptoms, they can be kept even under watchful wait. When there is relapse, the first line therapy, the preferred option is ibrutinib, but this is not the only option. There are several other drugs which are available for relapsed mantle cell lymphoma. So with this background, let's look at our study. And I want to highlight this, that if you want to do critical appraisal, the published paper should provide the complete information regarding the trial, which is clean and transparent. And it should follow the checklist provided by the consort. That's the consolidated statement for reporting of trials. And it should have all the components so that the reader can assess the methodology, whether it's valid or not valid, whether it's, it has external validity or generalizability to it or not. So all the components should be as per the consort statement in the published report. Typically, other than title and abstract, you have a structure of paper is focused as MRAD, where you have introduction as to why this research was done, methods, how they did the study and how they results. In results, the description is what they found, and in the discussion, what do they think their results, the results of their study mean with respect to the study as well as the other evidence which is available. So if you look at the consort checklist for introduction, it should mention why this research is being done, what was the research question, and what was the hypothesis. So let's see whether our present study has all these components available. So the authors start by saying that mantle cell lymphoma is an incurable disease. BR, that is bendamustine rituximab, is preferred given that it has a better efficacy and safety in elderly mantle cell lymphoma. They go on to say that rituximab maintenance helps because with R-CHOP induction chemotherapy, rituximab maintenance improved the progression-free survival. However, with bendamustine rituximab, there are 2 real-world studies which favored rituximab maintenance, but the phase 2 randomized trial did not support the use of rituximab maintenance after BR. Then they say that ibrutinib is used in relapsed patient, and in a phase 1B trial, ibrutinib in combination with bendamustine rituximab led to a 76% complete response rate in a denominator of 17 patients, saying that it is safe and efficacious. So what do you think? It looks like a good concept. They are looking at incurable disease, trying to improve on what is achieved by bendamustine rituximab. But the concern starts at the time when they start talking about maintenance rituximab. The present study, which is published in NEJM, started in 2013. However, the studies which evaluated maintenance rituximab after BR, they all are published after 2016. In fact, the real world data, which on the basis of which they have used rituximab maintenance, came in 2021 and 2022. So unless they had a real foresight, I'm not sure how the maintenance rituximab is justified. If they use maintenance rituximab because it's worked in post, after the R-CHOP, then again, we need to be cautious because the same study where it showed benefit in R-CHOP patients, the rituximab maintenance had a detrimental effect if there was another induction chemotherapy, that is RF, FCM. So I'm really not sure whether, you can extrapolate the data to bendamustine rituximab when you had that conflict in that study. The other thing was phase 1B data, which was only for 17 patients. Is it good enough to go directly from phase 1B to phase 3 based on the 17 patient data? It's questionable because it's not an orphan disease. It's not that you have no other drugs. So you do require a good phase 2 to prove the efficacy before you move on and randomize close to 500 patients to this combination. Let's move to see whether they have, clearly spelled out the research question. So research question follows the PICO format, that's population, intervention, comparator, and outcome. So if you read the last part of the introduction, they do see, you get to see the population that is older, untreated mantle cell lymphoma. You get to see the intervention, that is ibrutinib. You get to see the comparator, which is placebo. But what is not there is outcome. What they are trying to achieve is not very clear. And same holds true for hypothesis. It's not mentioned in the paper, though if you look at the protocol, which is provided as a supplement, it does state that ibrutinib in combination with BR compared to the placebo with BR will prolong PFS in this subgroup of patients. This is an incomplete hypothesis, and I'll show you what I mean by incomplete as we move to the study design, where I show you both arms. So coming on to the appraisal of the introduction part, it's not really a strong aspect here. The research question was not given, why this research, partly explained, and hypothesis was not available. Let's move to the method checklist of the consort. The published report should talk about the trial design, if there were any changes in the trial once the trial began. Should talk about the participants, the eligibility criteria, from where these participants have been accrued, details of intervention, so much so that you can replicate those intervention in your clinical practice if you were to practice this tomorrow. Outcomes, which should be completely defined, pre-specified primary and secondary outcomes. And if there are any changes which they made to the trial outcomes after the trial was started, with reasons. Sample size, considering what parameters were included for sample size calculation, any interim analysis with stopping guidelines, randomization, the method for randomization, the type of randomization, and how did they implement the allocation concealment, and how, who randomized the patient, who enrolled the patient, who assigned the participants to intervention. All this needs to be clearly spelled out to understand whether the randomization was a proper randomization or not. Same way, if there is a blinding, details of blinding and who all were blinded should be given, and the details of statistical method. So let's look at our study. I've taken this a slide from the EHA presentation just to explain what exactly are the comparator and the intervention arm. So this was a randomized double-blind phase 3 study where 1:1 randomization happened and patients were randomized to BR 6 cycles. And if they responded, they were given maintenance every 2 months for 12 cycles, meaning 2 more years of treatment. And the intervention arm continued ibrutinib not only with the backbone therapy, but even after the backbone therapy got over till there was progression or unacceptable toxicity. Whereas the comparator arm, the backbone remains the same, but they receive placebo instead of ibrutinib to the same time point of progressive disease or unacceptable toxicity with progression-free survival as the primary endpoint. So is the trial design sensible? Answer is that when you're comparing an intervention with the comparator and you want to see effect, I think randomized trial is something which you will look at. So that's right. So randomized double-blind parallel group placebo-controlled trial is something which they have written with a 1:1 allocation. So till this, it looks okay. What is not mentioned is that after the initial study started, in 2016, they introduced one more interim analysis, which they have not mentioned. And the reason for this was the event rate was lower. And this was in 2016. The second thing which comes in mind is the control group, okay. Placebo instead of any other active drug, and compared it with the active drug as continuous therapy till progression. So using an active drug, comparing it with placebo, using it till progression, automatically you are making your intervention arm stronger and the comparator arm weaker. So 3 versus 2 active drugs, fixed duration versus continuous therapy with active drug. And it's not that there are no other drugs available for mantle cell lymphoma. And it has been shown clearly that when we look at registration trials, many times weaker control arms are used to just give an undue advantage to the intervention arm. And this is quite prevalent in lymphoid malignancies. The next question comes, is the outcome being measured, that is progression-free survival, important for patients? We all know, we have been taught that only 2 outcomes matter to patients. Either the drug should make them live longer, or they, it should make their lives better. So improve quality of life, or both in the best case scenario. Anything else which you are measuring should be the surrogate for these 2, meaning if you improve your endpoint, the overall survival should improve or the quality of life should improve. But PFS is not the surrogate of OS in mantle cell lymphoma, and it's not a surrogate for quality of life in mantle cell lymphoma. However, you're giving a continuous therapy with an added drug, so it may come at the toxicity at best without any other improvement in OS on quality of life. There's an entire module on surrogate endpoints. Please do look at it and read the challenges which are there because of use of surrogate endpoints in oncology. Let's move to the participants who were included and from where. So more than 65-year-old patients who had mantle cell lymphoma, documented stage 2 to stage 4 disease, very good performance status of 0 to 1, adequate organ function. If they were excluded, if they were planned for stem cell transplant, or if they have CNS disease, or if they had comorbidities, significant comorbidities like stroke and intracranial bleed 6 months back, or if they had significant cardiovascular disease, or they were on drugs like warfarin and vitamin K antagonist, or any of the CYP3A4 inhibitors. Why such a eligibility criteria are used in trials? We all know they want a homogeneous population so that you can demonstrate the clear, clean effect of the intervention. And no features should be there in the inclusion criteria, or all those patients should be excluded where you worry about the safety, that because of presence of XYZ clinical condition, the safety should not be compromised. However, it does come with the price of less generalizability. And if you look at your real life situation, patients who are more than 65 years, there's a very high likelihood of comorbidities, more so the cardiac comorbidities or the cerebrovascular accidents. Many of them are on concomitant medications. Some of them are on medications which are CYP3A4 inhibitors. So is it going to be generalizable? Is it going to be generalizable to people who walk into your outpatient clinic, and whether you can use this data to your patients? Answer is probably no, because once you look at aggressive disease, a very relatively small proportion of patients will have performance status 0 and 1. Another important challenge with this trial did not address is that what about the dual antiplatelet therapy, which many of the coronary artery disease patients receive? And we know that ibrutinib increases the risk of bleeding if they are on dual antiplatelet. They haven't included, they haven't excluded, but we don't know. So how to apply these results to that subset? And the important thing is representation from LMIC. The trial did include patients from South America and Asia Pacific, but the representation is relatively poor if you look at the patients from LMIC. The subsequent part is focused on whether they attempted to avoid the systematic bias, which is the selection bias, performance bias, exclusion and attrition bias, and detection bias at different levels from randomization to the final analysis. And I'll come to one by one. So selection bias is, you look at how the assignment to interventions happened, whether it was randomized or not, what was the randomization process, whether the method was appropriate or not, and the randomization was sufficient to eliminate the systematic bias. And if they used methods to ensure allocation concealment from both investigators as well as participants. Because the challenge is that if this randomization process is not foolproof, then in that case, you're going to get differences between the two groups, which is going to change the ultimate outcome. So you will introduce a selection bias just by having an improper randomization. And again, in randomized controlled trial module, there is an entire discussion of what is proper randomization, what are the methods which do not ensure randomness. And an important component is that if you use methods where the investigators can come to know the next allocation sequence beforehand, they may not enroll patients who are sicker or older, or where they feel that they will not be able to tolerate the required treatment. What about the present trial? It used stratified randomization. Stratification was based on the prognostic factor, or what we call as risk score, just to ensure that both arms had equal number of patients with respect to low risk, intermediate risk, and high risk. They used random permuted block to just ensure that at the end of each block, there was an equal number. And by using the random permuted block, there was no way that investigators could know beforehand. Even if the randomization was happening on site, investigator could not know that what is the next randomization sequence which is going to be there. Another important fact here was people who were randomizing and those who were recruiting were different, because randomization happened centrally using an interactive web response system. And they were not given any randomization code. They were only given treatment code, so they didn't know which arm the patient is coming. So that's a strong aspect of the study, that they have eliminated the selection bias. Coming on to the performance bias, if you continue a study and you handle your intervention and control arm participants differently, you give more care, more information, more supportive care, better symptom control to your intervention arm as compared to the control arm, then you are introducing again systematic differences, and this is what we call as performance bias. Was it feasible, possible in this study? Unlikely, because the study had blinded the investigator as well as patients. So again, elimination of performance bias was a strong aspect for this study. What about the detection bias? So detection bias is that if the investigators know that a person is receiving active intervention or an intervention which is being the experimental arm versus the control arm or placebo, if they know beforehand, there is a very high likelihood how they are going to assess the response. And it has been shown, especially with progression-free survival, that if you have an investigator assess PFS versus an independent review committee assess PFS, there is a difference. So investigators tend to overestimate the progression-free survival. So that's why the assessors need to be blinded so that they don't know which arm the patient is coming to. The method of response is equally important, because if you don't use validated instruments for assessing the response or validated methods for response assessment, again, that can bring in bias, because it is not a very clear attempt, and not the same way you are assessing response into. Frequency of assessment is equally important because it can bring in the detection bias, because if you have an aggressive disease and your response scans are too far apart, you may miss the difference between the two treatment arms because you have not assessed them in time. And vice versa, if they're too closely packed, you're looking every month scan and you're trying to see the difference, there is a possibility that the 1 month difference can come in just because of chance, or that difference which you have detected is not really clinically meaningful to say that intervention is really helpful. So what about this study? Here they used physicians as assessors. Physicians, though they were blinded, but we all know, those who give ibrutinib, is that ibrutinib can cause skin rash, it can cause diarrhea, it can cause atrial fibrillation, several such side effects which can make a person understand that there is a likelihood that this patient is receiving ibrutinib. So this is not a perfect blinding for outcome assessment. However, as far as response assessment methods are concerned, they use CT scan, which is very well acceptable, and they confirm the complete response with PET scan and bone marrow, which is again completely acceptable method. And the frequency of assessment was also as per the requirement based on the disease temporal course. So if I have to say that, if we talk about elimination of detection bias here, it's not a very strong aspect of this study, given that there was no independent review which was performed for progression-free survival. Coming on to the exclusion or attrition bias, if there are systematic differences, the way there are losses to follow-up or withdrawals from the intervention arm as compared to the comparator arm, even that can introduce a bias, what we call as attrition bias. And to see whether there is such kind of bias existing or not, we need to look at the diagram and see that all the participants who entered, whether they were accounted for, each and every one should be accounted for till their last data analysis when they have conducted. And whether the analysis is done as per the group to which the participants were randomized to, what we call as intention to treat analysis. And the other thing which we need to see is whether the study was stopped early, and if yes, what was the reason? So what about this study? This is a consort diagram of this study, and it clearly gives who was screened, how many randomized, how many were allocated to ibrutinib, how many were allocated to placebo, and how the subsequent discontinuation of treatment happened and for what reasons. And if you look at it at the end, the analysis has happened as intention to treat. All those who were allocated to intervention or comparator were included in this analysis. So that's a good part about the study. I want you to focus on this. A significant number of patients in ibrutinib arm discontinued the study because of adverse event, as well as withdrawal of consent. So almost 18% in the intervention arm and 9% in the comparator arm. And how did they account for it? They did include them in intention to treat analysis. However, why a person would withdraw a consent from a trial, the likelihood is that either they are having side effects, or they feel that they are not benefiting, or they need to come too often for assessments or for the drug. And with all these three things, if these are the reasons, then probably the applicability of such study in the real world is going to be limited. The other challenge which came in with withdrawal of consent, that most of these patients who withdrew consent, the last response was taken as non-progressors, and they were censored at that time. And when there is a difference between the two, that may affect the overall assessment, what we are doing. The study assessed the quality of life using the standard QOL questionnaire. And this was performed until disease progression or till the final analysis of PFS. However, the challenge here is that those who were discontinued because of toxicity, for them, the end of study visit happened 30 days later. So if you had toxicity today and your quality of life is being assessed 30 days later, there's a high chance that the quality of life, which is bad today, is going to become, the scores will become better at that time. So how did they, account for all this into the impact on quality of life assessment? So at the end, since they performed intention to treat analysis, they gave a clear picture of who was, excluded for what reasons, who went out of the study for what reasons. So therefore, one can say that it's fair to say that, they had eliminated the exclusion and attrition bias quite well. Coming on to the, another question, whether they addressed all the preliminary statistical questions appropriately or not. And the first thing which comes in mind is the sample size there. Whether they calculated sample size based on the clinically significant effect using appropriate power as well as alpha. So if you look at the study, they propose that the study will be detecting 30% lower risk of progression or death in the ibrutinib arm with 77% power and one-sided significance level of 0.025. They did, as I said, 2 interim analysis and 1 primary analysis, and they accounted for these interim analysis. So overall, what do you think, 18 months? So if you look at that 30% reduction in the progression or death, that corresponds to that their baseline assumption was that 42 months will be the median PFS for patients who receive bendamustine rituximab and rituximab maintenance. And they want to improve 18 months over and above this by adding ibrutinib, not only with this backbone therapy, but even continuing till later. However, so 18 months looks quite good in terms of the numbers, but is what assumption of 42 months fine? Because in 2016, the study came in, which was the phase 2 trial. And in this, bendamustine rituximab showed a 54 months progression-free survival. And this is the time they actually added an interim analysis. So whether they needed to, increase the sample size based on, that now the study, the comparator arm is doing much better than what their assumption. So that wasn't done. The initial planned power was 80%. However, because they added an interim analysis, the power came down to 77%. And what they used was one-sided significance level of 0.025, meaning they were only expecting an improvement with the intervention, not a detriment or decline. And that was very right because they were using an active drug, which was to be continued till progression. So their assumptions were probably right. They accounted for alpha spending for 2 interim analysis in their final, primary analysis. And they said the p-value of 0.023 will be taken as, level at which they will say that it is significant. As per the consort checklist, the results should describe a participant flow, each and every participant, whether they received treatment, whether they were included in analysis or not, what were the dates of recruitment, and if the trial was, stopped earlier, baseline data for both groups of patients, total numbers analyzed for each analysis which they are doing, efficacy and safety, and whether that was as part of the originally assigned group, and then an analysis of outcomes where for each group, primary and secondary outcome analysis should be done with an estimated effect size and with the precision. And if you're talking about this 95% confidence interval with the hazard ratio is what is needed. And ancillary analysis, if there were any other analysis which were performed, including the subgroup analysis or adjusted analysis, and distinguishing anything which they had not planned and they decided after they got all the results to do them, what we call as, a post-hoc analysis or exploratory analysis, and they should present the harms or the adverse event in both groups. So you've seen this consort diagram earlier, and you can see clearly that they provided the complete study flow. The study started in May 23, completed in November 2014 with 523 patients. The median follow-up was almost 7 years in this study. And if you look at the baseline characteristics, they were well matched. Our few points to note, this is all performance status 0 and 1. Almost half of them were performance status 0. And there was a fair distribution with respect to the intermediate risk and high risk category which predominated in both the groups. And same way, the stage 4 disease, we know that most of these patients present with stage 4 disease, so it's fairly representative in terms of stage distribution, what we see. However, if you look at the distribution, the Asians were 18% and 16% in each arm. An important thing which I want to bring to your notice, the median time from initial diagnosis to randomization was roughly around 1.5 months, same in both arms, but you can see the range. It almost 9 years in one arm and 5 years. What does it mean? These are untreated patients, meaning these are the patients who are indolent and who remains asymptomatic for a long time, and now they are going to start. So a mix of patients who had indolent disease, which were also included in this particular analysis. Looking at a very important component, if you remember the diagram, we said 30 months of therapy is what we are looking at. 6 months of BR, 24 months of maintenance, and then they will continue placebo or ibrutinib even after that. But in ibrutinib arm, the median duration of treatment was only 24 months, and in placebo arm, it was 34 months. So that's something which we need to keep in mind, that even though they intended to continue it till progression, most of them stopped therapy because of the toxicity, because they did not progress because of toxicity at 24 months. So coming on to the primary endpoint, which was progression-free survival, and you can clearly see that there is hazard ratio is 0.75 with confidence interval, though these are relatively wider, the p-value is 0.01. And if you look at that, whether they provided all the estimates with the precision, answer is yes, that is given. An interesting thing here is that typically we see the trials report hazard ratio. Here they have reported stratified hazard ratio. Stratification factors were low, intermediate, and high risk MIPI. And if you see later in the subgroup analysis, the high risk did not benefit. So typically this hazard ratio, stratified hazard ratio, is driven by low risk and intermediate risk patients. You add a third drug to an active therapy and you expect that the complete responses at the end of 6 cycles should be better with your intervention. However, that did not happen. Numerically, it appears higher, but it's not statistically significant. So the premise that the activity is more when the ibrutinib is combined with bendamustine rituximab doesn't seem to be the case. If you look at the overall survival, there is no difference. One important point to learn from this overall survival curve is that the curves are crossing each other at several points. And when you see that in any curve, Kaplan-Meier survival curve, that the curves are crossing each other at multiple points, then that means that the proportional hazard assumption is no longer maintained, and you cannot use the same test for analyzing this kind of a overall survival curve. Another thing which I want you to note, that after 36 months, after 30 months, the ibrutinib arm started dropping if you look at the overall survival curve, meaning there were more patients who were dying because of probably the toxicity due to ibrutinib, and that was the reason why the curve dropped below. Let's look at the subgroup analysis. When we are looking at subgroup analysis, we need to see whether these are all pre-specified or post-hoc, because both have differences. If you have post-hoc analysis, typically because your study did not show the results as you wanted, many times you want to find out which subgroup it benefits more. And definitely that has to be taken with a big pinch of salt to say that any of these post-hoc analysis have any value other than generating a hypothesis for your next study, or trying to understand some differences in biology. Typically, subgroup analysis are multiple, so you need to keep in mind challenges with multiple testing where you can get a false positive result just because you're testing multiple times. The other important point is that these subgroup analysis are unadjusted. Okay, so they are not taking into account other factors. So these are unadjusted analysis. Having said that, they do give an idea whether within all subgroups, the trend is similar as to what you have seen overall. An answer here is that if you look at high risk, the intervention did not benefit this subgroup. And so to say that similar trend was there in patients who had mutated P53. So some subgroups did not get benefit as intended as per this subgroup analysis. The study said that there are no significant between group differences as far as time to worsening of quality of life was concerned. And here again, I want to bring back the point that the quality of life was not assessed at the time of adverse event and the discontinuation of patient, it was assessed 30 days later. Let's look at the toxicity. If you look at the, though any adverse event matters, but if you're looking at the drug trials, typically the focus is on grade 3, grade 4 toxicity. And you can see almost 81% patients here, 77% patients here had toxicity. What kind of toxicity? Infections. So pneumonia in almost 20%, diarrhea, which was higher in the ibrutinib arm. Similarly, rash, which I said that, it is something which we see in ibrutinib, which was higher here. So these were the things which were, alarming as far as adverse events were concerned. So typically at the end of results, the mental picture is whether the groups were comparable or not. And if they were not comparable, the final analysis has accounted or adjusted for all these differences or not. If there were appropriate statistical tests or there were any obscure statistical tests, because sometimes if there are obscure statistical tests, it should raise your antenna to say that, is there anything different which is going on to just make the study look positive? Data analysis as per the original study protocol. And here I want to emphasize that the protocol said that there will be an independent review committee which is going to analyze PFS, but in the published report, it's only the investigator assessed PFS which is written. A very, very important point when we read the results is whether the results are just statistically significant or they are clinically significant also. And there is an entire thing on magnitude of benefit module which is available. Definitely go through it, but let's see what's there in this study. So if you remember, in between, I had mentioned that in 2016, a study came in where the median PFS with BR alone was 54 months. And if you give ibrutinib at the time of first relapse, the median PFS, this is reported from clinical trial, is 25.4 months. So instead of using the strategy of combining everything together, if they were to use hypothetically these regimens sequentially, they would have got a 79.4 months PFS. And the study had a PFS of 80.6 months, probably at the cost of lesser toxicity. Was there a benefit of adding ibrutinib to BR during induction? I'm not sure, because there was no difference in complete responses. Actually, the PFS curve separated after 1 year, which means that once you finish bendamustine rituximab and you give ibrutinib along with rituximab maintenance, that's where the effect starts showing. The important thing that ibrutinib could be continued only for 24 months. All this needs to be interpreted in the light of adverse event which we saw. Significant, almost 103 patients in the ibrutinib arm, more than double, which discontinued the study because of adverse event. There were higher death rates during study as well as during follow-up in the ibrutinib arm. Higher infection rates, which we saw. Another challenging side effect of ibrutinib is atrial fibrillation. So again, even in the comparator arm, you had patients who were elderly, and that's why you did see 6.5% AF there, but the numbers are much higher in the intervention arm. What makes it very interesting is to look at the placebo arm, where there was 77% grade 3, grade 4 toxicity. If you look at the data of rituximab maintenance, when it is given after R-CHOP, the grade 3, grade 4 toxicity reported in the trial is around 15%. Why such high toxicity? Is it because of the bendamustine rituximab given before? Likely, because the similar thing happened when the rituximab FCM was given and then maintenance was given. Again, there was significant toxicity. So how do we justify this entire thing of using this regimen, taking the trial results on their face value? Let's look at a very good thing that this trial has reported the post-protocol therapy, and the study had a 7-year follow-up with 210 deaths. So if you remember our discussion on mantle cell lymphoma, the median overall survival ranges anywhere between 1.2 to 8 years. So if they had such a long follow-up, why they did not use overall survival as an endpoint instead of using PFS? And let's look at that there was no difference in overall survival in light of what the post-protocol therapies were used. This trial started in 2013. Ibrutinib was given FDA approval for relapsed mantle cell lymphoma at the roughly same time, 2013-2014. However, placebo arm patients, once they progressed, only 1/3 of them received ibrutinib at the time of progression. So even after there was no significant number of patients who received ibrutinib in the placebo arm, there is no difference in overall survival. So that's an important thing to note. Moving on to the last section of discussion. So the discussion as per the consort checklist should talk about the limitations, the generalizability and interpretation of the results. And after discussion, you should have information with respect to the funding source. So let's look at what the authors stated in discussion. They did discuss higher adverse event, and they actually suggested a close monitoring for infections and immunoglobulin levels, because once you give rituximab and ibrutinib both, your IgG levels go down, which may make you more prone for infection. However, at the end of all this, they did justify the design, saying that we were not looking at sequential use of bendamustine, rituximab, and ibrutinib. We wanted to improve the progression-free survival by giving all the drugs in the beginning, because that will provide a durable disease control. I don't think that logic applies anymore here looking at the results. They went on to say that even though there were more adverse events, but the quality patient-reported outcomes remain similar without addressing the challenge at the timings when they were measured. And they said that they did see a significant improvement in progression-free survival, even though they could give ibrutinib only for 2 years. So probably the continuous treatment is not necessary. Anyone who uses ibrutinib either for CLL or for mantle cell lymphoma knows that the minute what I mean is as soon as you withdraw ibrutinib from therapy, they start showing progression. So what happened here is that you are using two active drugs, two active types of active therapy, and you are just adding up rather than gaining anything, and at the cost of toxicity. Coming on to the conflict of interest, this trial was written by Janssen and it was analyzed by them. It was funded by them and the pharmacyclics, which were making ibrutinib. And the trial was written, the study report was written by the medical writer. And again, if you go back to the modules, you'll realize the impact of all this pharma funding, writing the trial, using the medical writer. All this adds to the conflict of interest and can have bias. And that's probably the reason why you're seeing the study design like that, as well as the discussion where they still justify using this approach and still highlighting the improvement in PFS. What are the implications for your practice? If you were to use this trial result and apply in your next patient who comes in the same age group, whether you'll be able to use this, I don't think the benefits are enough. These are not meaningful outcome. We would still prefer, based on the results, bendamustine rituximab alone with no R maintenance, frontline, and at the time of relapse, ibrutinib, because there are far too many harms in terms of infection. And we are talking about LMIC where we already have MDRO, atrial fibrillation, and deaths. We know that ibrutinib has led to certain cardiac deaths. So unless there was a strong reason that overall survival was better, I don't see the results of this trial are going to change practice. Even with generics, the cost is roughly around 2.2 lakhs. But what is not added here is the cost of monitoring, the toxicity management, and the hospitalization, which is needed for all these adverse events. So it's not a good approach based on this. So definitely the applicability is questionable. With that, that was my last slide. And thank you so much.
So thank you so much, Dr. Sengar. That was an incredibly thorough review, and I think a really good example of why critical appraisal is so important. And thanks for your thorough, systematic review of that. We're now going to have the chance to break into small groups and have small group discussions, both about this paper, the points that Dr. Sengar has brought up about this paper, and also about general points about critically appraising randomized clinical trials. We are going to put up a invitation to go into breakout rooms, and then after you've had some time to discuss in the small groups, we'll gather back just to wrap things up in about 40 minutes. So you'll get an invitation to go to the breakout room soon, and please enjoy that, and then we'll see you back in about 40 minutes.
We have about 30 more seconds and then everyone should be back. And I think everyone's in the main room again now, Scott, so whenever you're ready.
Okay. So I'd just like to welcome everybody back and just take a few seconds to wrap up here. First of all, I'd like to thank Dr. Manju Sengar for just doing a fantastic job of picking a great trial to review, and also doing such a thorough job of reviewing it and highlighting some really key points about analyzing and critically appraising a randomized clinical trial. Thank you very much, Manju. Really, really incredible. I put back up on the screen here all of our great facilities to go into many of the small group discussion rooms, and there was really excellent discussion there. And I think the people who joined really benefited from our expert faculty. So thank you to all of you. Thanks to you for joining. And if you haven't had a chance to do the main masterclass online, I'd really recommend it to reinforce some of the things you've learned today and to learn more about critically appraising the randomized clinical trials. Thanks everybody for your time, and we'll be doing more of these. So we'll be in touch when we're arranging more of these sessions. Thank you very much, everybody.